Good morning, everyone. And those who joined my previous session, we talked about the basic concepts of economic evaluation. And I hope you understood those, but just because I asked you a few questions and when I went through the answers, I realized that still there are some confusion. And this is expected. I don't think that this is totally unexpected because many of you are new in this course. So I completely understand this. But so today, I'm starting again with the very basic thing of understanding different methods of economic evaluation. And some of you rightly mentioned when I said, what is the difference between cost minimization and cost effectiveness? You answered that one is partial, one is full. That's right. But I wanted the answer a little detail. When I say detail, I mean that I wanted the answer saying that in cost minimization analysis, we only cover cost. We do not look at the consequences, or the consequences remain the same. We do not compare. We only compare the cost. So that's why this is partial. And in cost effectiveness, we both compare the cost and the effectiveness or the consequences. That's why it is the full. So you are considering both cost and effectiveness. That's the answer I really wanted. But yeah, some of you actually gave this answer, so that's great. So again, I just want to say again that we have economic evaluation methods which can be partial, which can be full. Partial economic evaluation only considers one component, that is the cost. It does not look into the consequences, or it does not compare between two alternatives. That's why we cannot call them as full economic evaluation. When it is a full, it means that it has to be a comparison between case and control, case or two alternatives. Let us put that way, two alternatives, and the cost and the outcome of the two alternatives are compared. If that's the situation, that's the full economic evaluation, okay? So that's one thing I wanted to say again. And another thing, of course, is the difference between cost effectiveness and cost benefit. I have seen that there is still a little bit of confusion among some of you. I want to tell you again what is the difference. Cost effectiveness, cost remains the same. I'm comparing the cost between two or more alternatives. I'm comparing the outputs of two or more alternatives, but this output can be like in natural units. One of you actually wrote this. I really liked it. Natural units, which means that it could be deaths averted, it could be hospitalization averted, it could be anything like severity averted, whatever is your output is, it should be presented in this way. Or at the end of the day, you can say DALIs averted or QALY gained. So I will talk about these DALIs and QALYs in later course, but I'm just saying that that's the natural unit. Now, for cost benefit analysis, you are comparing between alternatives, but your outcomes or outputs, whatever you are measuring, has to be in money form. Everything will be money. Cost will be in monetary terms. Cost is always presented in monetary terms. Your consequences will also be presented in monetary terms. And that's the main difference between cost effectiveness and cost benefit. Cost benefit is when you are transferring everything into money. I hope this is clear. Keep asking me questions if anything is unclear. You can use the chat function to put any questions, or you have the Moodle platform where you can ask me question. So keep asking if you have any confusion. Okay. Let's come to today's topic. Today we begin our discussion on the perspective now, or the viewpoint, what we call is viewpoint. For any economic evaluation, be it a partial economic evaluation, be it a full economic evaluation, your first consideration will be the viewpoint or the perspective. I have seen many studies when I review papers. I have seen many studies who were not clear what was their viewpoint, from whose viewpoint they are actually analyzing the data. We, as this graph, this nice figure shows, that we have in our analysis, we can have multiple players, right? We can have the patient, we can have the government, we can have the private provider, we can have the public provider, we can have the whole population. And from each perspective, we can calculate the cost. And here actually there should be another figure which says the insurance company. Okay, so everyone is a player in the whole spectrum of our work. You think about it, that you think and you will see that everyone is involved, including the insurance people. Now, when you are doing an economic evaluation, your first question would be, for whom I am answering this question? For whose viewpoint I'm interested in to calculate this. That actually determines which cost components you need to add in your calculation and which should be avoided, which should be, which does not need to come into your calculation. This, as I said, this becomes the primary thing. So you should always remember, when you start an economic evaluation plan, you first think about what is your perspective. What can be the perspective? And this is what I said, that the perspective or the viewpoint determines everything. Determines the major determination of this is the cost components, because at the end of the day, you will be costing the whole thing. Now, if your perspective for you as a researcher, if the viewpoint is not clear, you will mess the cost items, and you will be thinking like, oh, I should add this or should I add this? And this is what happened actually. I have seen that few other perspective cost came into when they're thinking of one perspective, because it was not clear. So at the end of the day, what the underline and bold thing is that an item may be a cost from one perspective, but not another. That's why you have to be very, very careful. When we do the economic evaluation, generally, in our context, we generally focus on 4 perspectives, okay? One is government healthcare provider, you can say, or government as a provider. Government is always a provider, right? Because government is providing the health services. So government health service or government provider, you can say that, or government perspective, whatever it is, government provider perspective, you can say all these, because ultimately government is a provider. Healthcare provider perspective, there is another that can also be said as provider perspective. And this healthcare provider perspective can be private provider, can be public provider. It depends on what you are doing. Then there is a patient perspective. Then there is a societal perspective. I will discuss each of these and will tell you how the cost components differ for all of these perspectives. And studies can be conducted from other perspectives, say, for example, as I say, purchaser, which is basically the insurance company. I hardly have seen studies in Indian context from an insurance perspective, but I will tell you where we can do, or our employer perspective. Those are also there, but we focus only on these 4. So if you understand these 4, I think that is good enough for you for conducting an economic evaluation. government perspective, when you are doing the economic evaluation from a government perspective, it means all cost that is incurred by the government to provide that service needs to be added. For example, I was giving example yesterday, the last day, about the COVID-19 vaccination. Let's come back to that example again. COVID-19 vaccination was provided by the government, right? Initially, private also provided, but let's think about that the majority of the vaccination was provided by the government. When the government, suppose you are now calculating the cost of providing COVID-19 vaccination from a government perspective, okay? The cost components that needs to be added then is the government staff time, government spend money on vaccine, syringes, transportation of vaccine, transportation of people. Government gave some initiatives, incentives to the government healthcare providers, like the staff. That needs to be added because that was government spending. Then government also, government did a lot of IC, right? You used to, whenever there was a phone call, you used to hear that we have to take COVID-19 vaccine. So those were all ICs. Apart from that, there are a lot of ICs everywhere. So maybe government spend money on that. So all those which government spent for doing COVID-19 vaccination, you have to identify all those and then you have to cost those. So that's the government provider perspective of doing COVID-19 vaccination. Now, suppose I'm interested in, okay, let me put that question other way. Suppose when we as individuals went to get COVID-19 vaccination, we went to the center. Think about a government center, huh? Don't think about the private center. Think about a government center. I hope some of you took the vaccine from a government center. So think about that I'm going to a government center to take COVID-19 vaccine. What happened? I spent my travel expenses. I lost my time because there was a long queue in the government center. I lost my time. Maybe I during while I was waiting, I got some tea and snacks because I was waiting for 2 hours to get vaccinated, etc. This is what I spent as an individual. Do you think the government will be interested to know how much did I spend on my travel? How much did my time was spent? Whether I took a leave from my office to go to get, actually we had vaccination leave, right? So whether I took that leave to go to vaccination center or how long did I wait there? Government will not be interested. So government perspective will never take into account these components. If these components needs to be added in your questions, that is patient perspective. I'm talking about patient. Now come to a disease. Suppose government come to any disease management example. Say for example tuberculosis. Say for example mental health. Say for example epilepsy. I know this group is from all these centers. Let me see who else are there. Yeah. Yeah. So let's think about any government program. Okay, diabetes or whatever. Think about any government program. Government is providing those services in a PHC or in a CHC or in a government district hospital. The services are provided by the government. If you are calculating the overall program, you are calculating the cost of providing mental health services for the government. You are calculating cost of providing NCD, cost of running NCD clinic by the government. You can either think of government perspective and you can also think of health provider perspective if you are collecting the data from the health providers, like if you are collecting only data from the facilities. Okay. Because why I say this, above facility, there could be several other things. If you are restricting only at the facility, say for example, you are calculating the cost of providing mental health services in a PHC. That means you are focusing only at the healthcare provider. You are not thinking of the whole government perspective. Because apart from that, apart from the PHC, there could be planning, there could be planning at the higher level, there could be monitoring at the higher level, there could be several meetings, trainings at the higher level. When you are thinking of the healthcare provider, that is the PHC, you are not considering those broader things, okay? So there is a difference between government and healthcare provider. When I gave you the example of the COVID-19 vaccination, you have thought about it. Like I thought about everything. I thought about the whole vaccination program. And I was thinking like what government did. Government did IEC. Government did, and for the whole country, government did that. If you are interested to do this kind of analysis, it is a government perspective, like government health service perspective, because you are thinking everything to cover everything, starting from the central level and going down to the community. Because you remember I said that government is doing IEC, government is, because IEC and everything was done at the central level. Planning was done at the central level. Vaccines were transported from the central to state to district to the ground level. So I'm considering every layer of it. That's the government perspective. That's a broader. Now, if I am just thinking that, no, I just want to see what was the cost of providing COVID-19 vaccine through a PHC. That becomes healthcare provider perspective, because you are then ignoring the upper layer of those. You are ignoring few parts of it. So it's the healthcare provider. You are now coming to the healthcare provider. Similarly, several private hospitals also gave COVID-19 vaccination. So if you want to really look at what was the cost of vaccinating one person in a government hospital versus a private hospital, that becomes your healthcare provider perspective. Okay. Any of this perspective, healthcare provider, whether it is government, private, government health service, they don't care about what is happening to me. They really don't care. Because if I'm spending my time or if I am losing my wage, doesn't matter, because they're not concerned. That's not their perspective. So you have to be careful here. When you are thinking of healthcare provider perspective, or when you are thinking of government health service perspective, don't think about the person, because they are not interested about us, like the person expenses. So which perspective is interested looking at the patient or the person is the patient perspective. May, like in COVID-19 case, it may not be always patient, but the perspective name is patient perspective, okay? Think about any disease, diarrhea, pneumonia, meningitis, diabetes, hypertension. Hypertension is a condition, acute coronary heart disease or whatever. Think about any disease you can think of, okay? If I am suffering from a disease, I go to maybe doctors, maybe pharmacy, maybe I hospitalize. So all these expenses related to me, my disease, only one disease. Generally, when we do a patient perspective, we consider only one disease. You take into account all expenses. I will tell you in detail about this, all this perspective costing. But now, for example, suppose I am a diabetic patient. I need to go to my physician every month to get checkup. I need to go to a diagnostic center to do my blood test every month almost, or 3 months. I have to go to the pharmacy to buy my medicines. All these expenses are my expenses as a patient. So this is patient perspective. So when you are thinking about a patient perspective, and think of all this. Now, suppose because of my illness, my friend or my neighbor or my family member, they are caring for me. I'm so sick. Even say for example, fever. I'm having fever, and the fever is so bad that my household members are taking care of me. They're spending time for me. They went to, because I had so high fever that I could not go. My family member went to get medicine for me. That's also my cost, my disease related cost, patient cost. Okay. So patient meaning my disease, the disease of the patient, and any related people to that. All expenses that is out of pocket plus time, as I said, time loss, income loss. I will come to those details, as I said, in later days, other days. But those will be in patient perspective. Okay. Now coming to the societal. When I do a costing from a patient perspective, I took into account only the patient. Now suppose, and as I said, provider is not interested to know what is happening to the patient. Now suppose, because of TB, tuberculosis, a young man of 25 died. Okay, I'm giving practical example from my studies. 25 died. What happened? If you think broader, the society lost that person. 25-year man, meaning he was supposed to work up to at least 60 age. That if you think 60 is the retirement age, if you think 65 is the retirement age, that person was supposed to work till that date. That means society lost a person. So it's a societal cost. Okay, so that means it's not really a patient cost. If you think about the patient, if you think about the family member of the person who died, they will, what they will think, what will be their cost, whether their cost will end. Their cost will end with the rituals of the death. That's the end of the patient perspective cost, right? Whatever the rituals happen because of the person's death, that's it. But then coming a much broader picture that the society lost something because society lost that person. So that's the societal cost. When you start thinking about costing the mortality, costing the permanent disability, suppose a diabetic patient, he had stroke and then he is paralyzed and he was 45. He lost at least 15 years of his life because he is now in wheelchair. Society lost that productivity because he is now paralyzed, he cannot work. So that loss of the society because of permanent disability is the societal cost. I hope you got it. So basically, societal is the broadest perspective which takes into account patient. So don't think that societal will not take into the other components. Societal will take into account basically societal meaning all cost, irrespective of who incurs them. You say the definition, all cost, regardless of who incurs them. Doesn't matter whether it is a government cost, whether it is a private sector cost, whether it is a public sector cost, you need to calculate each and every cost and go broader. It's not only just you club patient, provider, healthcare provider, and government, and then you are saying societal. That is okay, but your broader societal should be everything, the indirect effect of anything. I hope, suppose I'm giving another example to make you understand. So suppose you are calculating the cost of vaccination. Childhood vaccination. Childhood vaccination is the government cost because government gives the vaccine. It's the patient cost, meaning the our cost because we are taking our children to the vaccination center. We are spending money. We are spending our time, etc., etc. So all this perspective. If the child is not vaccinated, her cognitive development may be less or something like that. That's why she will not perform good in her education. That's the societal. If you try to consider that cost, that is much broader than just thinking about how much do I spend, how much the provider spent, etc. Isn't it? So that's the societal. Here are few examples. as you can see, if I say these are the main payer is the insurance. So insurance is interested how much I am spending, like how much people are spending on hospitalization, consultation, medications, because they will reimburse, right? What the payer does, what the insurance does, they just reimburse, no? So they are interested in this. So hospitalization, when I say hospitalization, it is actually the hospitalization. If it is a cost of hospitalization, then it is government, yes. But if it is the charge for hospitalization, charge meaning what I'm paying, that becomes a patient. It may be a little complicated for you now because I did not tell you yet the difference between cost and charge and price, etc. But think about like what I am paying is the charge, what government is paying, government is incurring is the cost, right? So all these, so transportation, food, etc. Think about it. Is the government interested to know how much do I spend? As the examples I gave, transportation, no, they are not interested how much I am spending on food while doing a treatment. They are not interested how much accommodation I'm paying for my treatment. For a treatment, I may go from Delhi to some other state to get a treatment. Government is not bothered about that. Like government perspective is not bothered about that. But societal, yes. Patient, yes, because that's the patient cost and societal includes everything. So as you can see, for everything, societal is yes, 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 yes. Because societal is the broadest perspective. It takes into account everything. Pain and suffering. Does the government is interested to know for a disease how much suffering you are going through? No, they are not interested. But as a patient, yes, you are bothered. If you want to cost it, yes, you have to cost it. And societal, yes, again. Time loss from work, informal caregiving, the child is sick, the mother is caring for the child. Yes, of course, it's a societal cost because the mother is spending the time. And then it's of course the patient because the mother is taking care of the child. So all this. Now, welfare, education, the payer may be interested, but the government, as you see, government is probably the narrow perspective, okay? The narrow because it only considers what the government is paying. So most of these are no for the government, but societal, everything is yes, and patient also is good number of components will come when you are considering a patient perspective. Ex Explain the answers a little bit. Why I said you all answered this correctly, that it is a societal perspective. Broadest, as I mentioned, because societal takes into account everything. That's correct. That's absolutely correct because you take into account everything, that's societal. Time spent by caring a child is patient as well as societal. Travel expenses, patient as well as societal. I would not say this is payer because payer is not generally interested of what I'm spending. Generally, have you ever heard that insurance company reimburse your travel expenses? Generally, no. So when you are thinking of a perspective of a patient, of you are thinking of a perspective of a societal, then that's the travel expenses comes from. Prices of vaccine syringes, most of you answered it rightly. That is a government provider perspective. That's absolutely a government provider because the price. So that needs to be paid by the government. That's one. Expenses. Here, I think some of you make a little mistake. Again, that's because I did not tell you the difference yet. So basically, when I say expenses, there are several terminologies, like the way I started last day now, that we should, after this course, we should not be using cost effectiveness as cost benefit like the way we do generally. No, we should understand, and then we should say whether it would be a cost effectiveness or a cost benefit. Similarly, there are a few other terms: cost, charges, expenses, prices, which I have seen people keep saying like very normally without thinking that cost, price, charges, everything have a different meaning. Expenses, it has different meaning in economics. So at the end of when I talk about this, at the end of all the sessions, you should also know what is expenses, what is cost, what is charge, what is price. These four things are not the same. Okay, that's why I know that I did not tell you yet. That's why you had a confusion. So basically, expenses, when I say expenses, it is from a patient perspective, like how much I'm spending. Basically, when it is cost, then it comes from the government side. But if it is or the provider side, if I say the cost of diagnostic test, it becomes a provider cost or a government cost or something. But when I say expenses, that means it's basically paying by the patient or the payer or the, because diagnostic test, of course, the payer is also interested. Insurance, we get reimbursement. So payer will be interested to know how much I'm spending. That's how we get the reimbursement of any insurance coverage, right? The treatment of this, or the complication of meningitis, I would consider is as a societal, because that's a very broad thing. So you are not only thinking about meningitis, you are going to a complication and thinking of it, and the treatment here, that your dilemma could be that I did not mention whether it was a treatment cost or it was a treatment expense. But I would consider it as a societal in any way, whether it is a government or it is a patient or anything, but ultimately it is a societal, because this is a very broad perspective, right? It's like it's not only restricting the costing of the disease, it is going beyond that. So it's a societal, and death of a person is of course a societal. Yes, Hemant, I totally agree with you that treatment require hospitalization, travel expenses. That's why I'm saying it could be a cost to the government or the provider. It could be the government cost to the patient. It is, of course, to the cost to the society. That's why it's the societal. It's broad that you need to consider probably everything. That's why I said societal. Like the way I'm saying the death is of course a societal, right? Because it is taking into account everything. Hope that you have a clear idea of which perspective you should be taking while doing a cost analysis, and you probably appreciate why I spend more than half an hour talking about this, just because it is so important, because you have to figure out which cost should I take into this and which cost I should ignore based on my perspective. Coming to my point again, the cost effectiveness. So as I told you, cost effectiveness meaning comparing two things, one program, one comparator, cost and consequence. What would be my study design? How I will be calculating the cost and the consequences, what I should do. This all next half an hour, I believe, is on that, how we are going to do this study design. I'm sure some of you have heard about decision tree model, some of you have heard about Markov model. Let's talk why we need a model, or else if we don't construct a model, what we can do to do this cost effectiveness analysis. If I give you the example, like at George or many organizations, those who are involved here, I'm sure you have many randomized control trial. Now, why I'm talking about randomized control trial? Because in epidemiological term, this randomized control trial is the most robust. I'm not going to what is randomized control trial and on that. That's not the focus of this talk. But the point is that as our city is considered the best, the robust. So that's why I'm giving the example of our city. And I know of all of you who I know that you are all involved in different RCTs. Now, suppose you want to do a cost effectiveness of your RCT, of the problem you are dealing with. See, I'm talking about cost effectiveness, not benefit. So I'm not going to do monetary value of my outcomes. I will be in natural units. Now, any RCT, think about it. Say, for example, smart mental health, which was a prominent one. I know currently there are many actually mental health. There are in chronic kidney disease, there are interventions. There are epilepsy, there is intervention. There is intervention for following up hip replacement, joint replacement. Now, if think about your program, one RCT you are working with. What the RCT did, it chose participants based on which we want to answer a question, right? We want to see whether stigma reduced because of my stigma related to mental illness reduced because of my intervention. That was my answer to my RCT, and for doing that, we did that RCT. Think about your RCT, okay? So you are looking for an answer, one answer. For doing that, you are choosing your study participants in such a way so that you get that answer, isn't it? You do like you chose the states, you chose the areas, you chose the facilities. First is based on your convenience. And secondly, where you can do your research in most feasible, best possible way, because you want to get an answer. That's correct. That should be the study design. And RCT everywhere is done that way. But now think about the economic evaluation of that RCT. So the RCT will give you the answer of your question. But suppose I am doing a RCT of a drug which will help me to control, which will help my glycemic control. Okay? A drug which will help my glycemic control. To do this RCT, I chose 2 different states. I chose different settings. I chose my patients, participants in such a way where I ensure that I will be able to follow them up for a certain period of time, etc. So I made sure that I get the answer to get the efficacy, which means that whether my drug actually reduce the glycemic control or manage the glycemic control of the person. That's my ultimate look, like ultimate focus at the end of, say, 1 year of my trial. Think about the real life situation. It's not like that. It's not like that state where you did actually could be very different from the other states. The participants you recruited, when you go to other, you might find it extremely difficult to get those number of participants in reality. There could be several other. When the government does this, there could be the drug which I was actually testing that may not be available at some point, and that makes things very different. So, effectiveness, when it goes for the broader from when it is the actual actual government implementation, it may be different from the efficacy. So basically, your RCT will tell me that yes, the glycemic was controlled with my drug, but it will not tell you because of the glycemic control, my other outcome, my quality of life improved, because I am not suffering from other consequences of poorly regulated glycemic control. Those impact will not come from RCT. But for economic evaluation, ideally, you should be considering those. because that's your long-term impact. That's why coming the time horizon. RCT generally is a time period. Can you do really okay, let me give you another very nice example of HPV vaccine. I'm sure you know human papilloma virus, which is for cervical cancer. It is meant to give the vaccine for 10 to 12-year-old girls. You give the vaccine. If you do a trial-based economic evaluation, you will cost that vaccination procedure, and you will see the outcome, which is a short-term outcome. But over the years, it will actually prevent cervical cancer up to the age of 60, maybe. Where is that long-term impact? And because whatever my proper glycemic control, because of my vaccination, I may save a lot of cost. Because I'm vaccinated, I may not have the disease. I may not need to go for treatment of the disease. And all this cost saving, or I, because of my better glycemic control, I will not have the other complications. Those are all the cost savings, which is not possible if you go with the RCT. But I'm not saying that does not mean that you will not do the economic evaluation along with the RCT. That is also possible. But then you may need to add on, get the data from your RCT, and then try to build up a model. That's the model, decision tree, or Markov. Depends on what you want to do. I hope it is clear why I cannot do. I'm not again saying I cannot do. I can do, but that's a limited. That's not a like a really broad economic evaluation. Because the reasons I say efficacy versus effectiveness, short term versus long term, cost savings and outcomes, you are looking at a very narrow, only that period. If you really want to go broad, you have to think of doing a model. And the comparators, when you do RCT, generally 2 to 3 arm, right? Maximum you take 3 arm, 1 control and 2 different arm. But think about the real life situation. When the government thinks of introducing something, is it really 3? No, there are unlimited choices, and the government has to take a decision based on all of this. So a modeling can help you, taking into account the broader outcome, the broader cost saving, everything, and that helps the government to take a decision based on your modeling. So you definitely, again, I'm saying that you can definitely do along with the RCT, take the RCT data. You can do only up to 1 year or whatever the RCT period you do the economic evaluation, that is perfectly okay. But if you want to give a broader perspective, like a very good comprehensive economic evaluation, then go for the longer duration. How will you do this? Here are a few examples. I will share a couple of very nice papers, so you can go through. Those are very easily written, and I took the examples from there so that you can easily understand. Suppose my decision is whether I should have a neonatal ICU in a district hospital. That's my decision. So in a decision tree model, there are few things you have to think about. You see that there are different types of nodes. The symbols are different. This is a rectangle one, this is a round one, and this is a node. You notice, right? These are different because this has some meaning. This is the decision node. Decision node, the decision tree will start with the decision node. That is whether to make a NCU or not. That's the decision. Yes or no. That's your decision. So decision node cannot be somewhere here in your whole decision tree model. It should be at the beginning. The decision has been taken, whether it is or not. So when a child, and there should be a target population always. For your RCT also there is a target population, right? You always start with a target population. So here also your model also start with a target population. You can take based on your thinking. That's your project, whatever it is. While understanding this, you think about your project, but or when you go back, think about your project. So there are two decisions. There are two chances. Those who are, if there is a NCU, the child will be alive for at 28 days of treatment, they will be alive or they will be dead, right? Dead meaning this is the terminal node. And this node denotes it's the terminal. Here, there is a chance. This is called chance node. This node, what is it saying? That it may have disability, minor, major, or no disability. And then it will end here. That's a simple model, okay? And similarly, for the no case, the same thing will happen. There will be, the child will be alive. The alive child will have chances of no, minor, major disability. And there is also a chance of death. As soon as the death, the terminal. As soon as this, because living with this disability, we stop here, our model, and that's the terminal node. Couple of things to note here. One is that this is unidirectional, you see. We never said whether it will be major disability and then going back to minor disability and coming back to major disability, like those chances. We did not take those chances. We just said one thing will happen. Either there will be no disability, there will be minor disability, major disability. That's it. It's a simple model, okay? So there are few things you should remember when you do a decision tree. So based on your idea, you need to make this decision tree. And all these nodes, the chance nodes, are the probabilities. What is the, or the proportion? What proportion of percent, what proportion of, if there is a NCU, what proportion do you think will be alive and what proportion will be dead? So that's a number out of 1,000. So first 1,000 is divided into SNCU and no, yes or no. And then the rest will be divided into this. And then the rest will be divided based on the chances. The paper I will be sharing with you, they have given this calculation. Because of time, I'm not going through this, but if you find any difficulty, please post a question. But I think it is very clearly written how the chances, the percentage are calculated at each stage. Coming to a different decision tree, another decision tree example. This is a vaccination cohort, okay? Either vaccinate or no vaccination. If you, that's a decision tree model for, say, for example, a rotavirus vaccine, okay? Which is for the diarrhea, a specific type of diarrhea. This specific type of diarrhea, if there is vaccination, vaccination cannot be 100% effective, right? So there will be some children who will still have diarrhea. Among those children, some will be having medical visit, some will be having hospitalization, some will die. All these are terminal nodes. And those who are not vaccinated, they will also have no, it does not mean that I did not get the vaccine, the child did not get the vaccination, meaning they will not have the disease or they will have the disease. No, there is a possibility. A proportion of them will have the disease, a proportion will have not disease, no disease. Those who will have disease, similarly, they will have a OPD visit, they will have a hospitalization, they will have a death. This way, you have to create the decision tree. One point to note here is that decision tree is generally for the infectious disease, which ends at one go, right? Like the rotavirus. It has a quick ending. So you can do a decision tree because it's not very complicated. If you think that no, after some point, or this hospitalization case may become a medical visit case, and the medical visit then it or the no diarrhea case again become a diarrhea case, or the diarrhea case itself, which was just at medical visit, it gets complicated again. If you take into account all these complications into this account, then I'm telling you what will happen is the Markov model. So a couple of things you remember, that this is the decision node. Vaccination or no vaccination is your decision. See, this decision node is nowhere in your decision tree. All those are chance not. These are chance of vaccinating, chance of not vaccinating. No diarrhea, no diarrhea, diarrhea, no diarrhea. These are chances. These are chances of going to medical visit, hospitalization, death. And these are all terminal. You end your analysis here. Okay. I can show you another, but yeah, that's another. This is a complicated decision tree, but still this is decision tree because I'm all these arrows. I show you another thing. You can see the arrows are unidirectional, just going one way. It is not coming back the way I'm talking about, huh? See, it may be, this is Hib pneumonia. It can be Hib meningitis, it can be Hib pneumonia, it can be a private visit, it can be a death, it can be a minor sequelae. This is a complication. But unidirectional complication. I'm not saying that person, the child who had a Hib meningitis, it became, he was cured and came back again to the previous situation. I'm not talking about all those complications. It's just unidirectional, but a little bit complicated, okay? So that's still because the arrow is one way. This is the Markov model. What is it? Basically, going here and there, coming from this state to this state, severe to well, and well to again severe, then mild, mild to severe, like different disease states. And this is applicable for non-communicable diseases which has a long span. You can go on like doing how the disease, there is a possibility, a chance of coming back to the other state of health. So if you want to do this, of course, you understand that Markov is a little complicated model, but it takes into account all these transition from one state to another state and then coming back and then going back again. So all these, if you really plan those, that's the Markov, okay? So what happened? The difference between this is, as I say, this is the sequence of event. Like I will have this, I will have this, but basically the one I want to tell you is unidirectional relationship. Only you are thinking about the possibility different events which may occur because of this or without this. But Markov, as I said, will take you through different disease states over time. Direction and the speed, how quickly it will come back and come back. One thing here to mention that how will you get these probabilities? You see that the chances, the probabilities, this is what absolutely required to do this thing, like the decision tree and Markov. So your RCT, if there is RCT, very good, you have some data. But then all probability you will not get from your RCT, as I mentioned, because your RCT will end at some point. If you go on with the decision tree model, you have to look at the literature. You look at the literature and see what proportion of the patient may have the severe case or what proportion will be from a mild state to a major state or the major state to come back to the mild state. So all this information you really need to gather from your from the literature review. So that's the difference. And as I mentioned, decision tree is basically for once only, like a short-term event, which will not happen like a longer-term effect. So decision tree can be for that. But Markov, as I mentioned, it goes on talking about several things. It takes into account several other things. So that's basically the difference. I know this is a complicated area. That's why, as I said, especially this disease model, I request you to go through a couple of references, which I will share immediately after this class. And please have a look. And if you have any other question, I think it will be clear to you. Few things you just need to remember that decision tree is for a short term, the mostly infectious disease, which will end at a certain point of time, and you are doing a unidirectional and trying to figure out what are the chances of having different events under that condition is best for explaining through decision tree. But when you are thinking for a broader, like a very any chronic disease, which you can imagine, right? Any chronic disease, the person may feel better, person may get relapse. I was hearing like epilepsy, it may be good, and then if there is some effect, then it come back. Similarly, for probably for mental illness, it happens. So you know your disease better than I do. So think about your disease, whether there is a possibility. If it is a non-communicable disease, definitely there will be the states, different states of your the disease condition. If that is the case, consider Markov. Otherwise, go for this decision tree. Let me know if you have any question on this. We will be talking about this more in terms of, in terms of how to do this, of course. But I would really suggest you to go through the papers I'll share and let me know if you have any difficulty in understanding the issue. First thing is understanding, and then by doing, that is a different exercise altogether. But if the concept is clear, that makes many things easy. So there are two things I told this morning. One is perspective, one is this two decision model thing. Please feel free to ask any question, or if you have anything, let me know. Thank you so much for your attention.